So, dear students, today we will talk about the functional anatomy and components of the masticatory apparatus, their characteristics and relationship, examination of orthopedic diseases and the history of the disease, and the rules of its management. So, there are two theories of maxillofacial growth. First of them is the genetic theory. It states that all growth is controlled by the programmed influence of genes. And the second theory is a remodeling theory. The growth of the craniofacial skeleton is carried out due to bone reconstruction. So here we could see the reconstruction of the bones. So the reconstruction, or it is also called the remodeling, it is a selective apposition and resorption of bone on its surface. So on the right side, we could see the process of deposition, and here is the process of resorption. So there is a second theory, remodeling theory. If we talk about third theory, it is called the sutural theory or suture theory. It claims that the sutures primarily determine the growth of the bones of the craniofacial skeleton. The forces of the expansion of the seams lead to the expansion of the bones, which in turn encourages the growth of the craniofacial skeleton. So here you could see the growth of the maxillofacial region. The fourth theory is the cartilaginous theory. It claims that the cartilage determines the growth of the craniofacial skeleton. Cartilages are responsible for growth, and bone only replaces them. The fifth theory, it is the theory which we use in our practice when we work with our patients, when we make an orthodontic treatment. It is the functional matrix theory. And nowadays, it is the most respected theory, the functional matrix theory. The origin, form, location, growth, and maintenance of all bone tissues is always secondary to compensation and the need to respond to chronological and morphological previous events or processes that occur in specifically related known bone tissues, bodies, or functional spaces. Here you can see, as the evidence of this theory, here you can see the hydrocephalus, which is a proof of the functional matrix theory. There are two main types of growth movement in this theory. If we talk about this theory, there are two types of growth movement. It is remodeling and displacement. If you remember, before we talked only about the remodeling theory, where the resorption of the bone and apposition of the bone. But if we talk about functional matrix theory, there is not only the remodeling, there is also a displacement. So here we can see the processes of the remodeling is apposition and resorption. So changing the size of each bone, successively moving a component of the whole bone, given the shape of the bone according to its function, fitting the bones to each other. It is the remodeling. And also there is a process of displacement. So here is only the remodeling, but if we will see on the whole picture, we could see the displacement of the bones in our maxillofacial region. So the displacement is a physical movement of an entire bone at the moment when apposition and resorption take place in it. So here is the process of displacement. So you need to remember two processes, remodeling and displacement. Displacement, it is a physical movement of an entire bone at the moment when apposition and resorption take place in it. So here you can see with a black color, here we called them negative spaces, and the white color, there is the positive spaces. So if we have a patient at the age of, for example, 11, so it is a growing patient, if we will make or push a force on the negative space, here we will make a bigger resorption of the bone. And on the other hand, if we will make a pressure on the positive space, here there would be the processes of apposition. So we use this in orthodontic when we make an expansion of the maxillary, when we do not make the protraction of the lower incisors, we make some leveling bypass and other techniques. So it is very important to know that there are negative spaces and positive spaces, and that there are processes of remodeling and reposition in the growing patients. So the next slide is a simplified diagram of the growth of the lower jaw. It is important to know that the lower jaw doesn't just grow. Better to say that it remodels and moves down and forward. Growth directions that include periostal resorption are indicated by arrows. So you can see these arrows. So as we talked earlier, there is a negative space in the area of the lower incisors on the vestibular plate of the lower incisors. So we could see that there the process of resorption. If we talk about lateral spaces of the mandible, it is a positive spaces. So here we could see an apposition of the bone. So growth directions that include periostal resorption are indicated by arrows that enter the bone, and growth directions that include periostal apposition are indicated by arrows that exit the bone. So now a few words about the anatomy of the lower jaw. The lower jaw is an unpaired bone consisting of a body, a cellular part, and two branches. Each branch, rising up, ends with two appendages. The front one is coronal. Here is the coronal process, and the back one is the condylar process. The upper part of the condylar process is called the head of the lower jaw. The mandible notch is located between the processes. So here is the mandibular notch. The body of the lower jaw in its shape resembles a tubular bone. Inside it lies the mandibular canal. Here is the canal of the mandibular, which contains a vestibular nerve bundle. The mandibular canal opens on the inner surface of the jaw into the mandibular opening. We also call it the foramen mandibular, and on the outside near the chin opening, we call it foramen mentale. Here is the foramen mentale of the lower jaw of the mandible. The body of the lower jaw passes into the alveolar process, having two bony ridges on the sides, one of which runs along the outer surface and is called the external oblique line. So here we could see the external oblique line, and the other is located at this level only on the inner side, called the maxillohyoid line. The maxillohyoid line is the place of attachment of the maxillohyoid muscles. External and internal oblique lines serve to strengthen the lower molars and protect them from loosening during transverse chewing movements. The external and the internal oblique lines are the limit of the atrophy of the alveolar process in case of tooth loss. Near the corner of the lower jaw, on the outer and inner surface, there are sharply expressed roughnesses that serve for attachment of the masticatory muscles. The masticatory tuberosity, we call it the tuberosity masticarica. Here is where located the tuberosity masticarica. For the attachment of the masticatory muscles, there is the masticatory muscles with the red color, and the pterygoid tuberosity. We call it also tuberositas pterygoida for the attachment of the internal pterygoid muscle. Here is the I'm sorry, tuberositas pterygoida. Here is where located, and this is the internal pterygoid muscles. Here is the nasal-maxillar complex. Here we could see the horizontal lengthening of the bony arch of the upper jaw, and it occurs due to the process of remodeling of the maxillar tuberosity. As we could see that the upper jaw, the maxilla, doesn't grow forward, it grows distally by the process of remodeling of maxillar tuberosities. So here as we could see that, for example, the anterior nasal spine, as it was on this side, during the growth process, it is on the east side, but we could see that the process tuberosity, it becomes bigger. So we said that horizontal lengthening of the bony arch of the upper jaw occurs due to remodeling of the maxillary tuberosity. Remodeling of the next maxillary complex in the frontal plane. During remodeling, bone resorption occurs in negative fields area. It is marked with the minus sign. So here you can see it. Here is the negative spaces. Here are the negative spaces. And there are also the positive spaces. On this side, this side, this side, this side, there are the positive spaces. And we remember that in the areas of the positive spaces, there are the processes of the apposition of the bone. So we saw that the growth of the nasal and maxillary complex in the frontal plane, when somebody answer us, what is the shape of the growing of the maxillary complex, we talk that it is a V-type. So we could see that is also simple with a V. So we call that the growing of the maxillary type, it is a V-type. It seems like a V. Anatomy of the upper jaw. The upper jaw is a paired bone, each half of which consists of a body and four processes: a frontal, maxillary, alveolar, and palatine. Frontal and maxillary processes connect the body of the jaw with the same names bones of the facial skull. The alveolar processes of both halves of the upper jaw form the maxillary arch. So we could see that there is a right side, right half, left half, and together they form the arch, maxillary arch. The palatine processes of both halves of the upper jaw being connected by a sagittal seam. Here is the palatine processes. It is a sagittal seam. Participate in the formation of the hard palate. So all this together makes a hard palate of our patient. Atrophy on the upper jaw, in contrast to the lower jaw, is limited to the alveolar process, rarely moving to the body of the jaw. Now a few words about counterforces of the upper jaw. In areas where the tension from chewing pressure is high, the bone thickens, forming counterforces. All chewing pressure which is perceived by the dental arch is transmitted by counterforces. There are 7 counterforces. On the maxillary transverse upper, you could see the counterforces with the yellow color. Here are the maxillary counterforces. maxillotransversal lower counterforces, orange color, middle upper jaw with the red color, and lateral maxilla of the blue color. Here you could see also the counterforces of the mandible with the brown color and the green color. So here are all the counterforces of the maxillofacial region. Now a few words about muscles. Masseter muscle, or we call it also the musculus masseter. The superficial part of the muscle starts from the outer surface of the zygomatic bone. Here's the zygomatic bone of the outer surface, and the front 2/3 of the zygomatic arch. You can see also that it is connected with the zygomatic arch on the 2/3 of the zygomatic arch. The deep part begins from the back third of the lower edge and the entire inner surface of the zygomatic arch. The muscle is attached to the masticatory tubercle of the branch of the lower jaw. So we could say that this is the punctum flexum, and this is the punctum mobile. Temporal muscle, or musculus temporalis, starts from the frontal scale. The scale part of the temporal bone, the large vein of the sphenoid bone. Bundles of fibers of the temporal muscle converge into one powerful cord, which turns into a tendon. So here begins the tendon, which passes under the zygomatic arch. So it is, we don't see it, but here is the zygomatic arch. And this is tendon, lies under this zygomatic arch. Passing on the zygomatic arch is attached to the coronal process of the lower jaw. This is the coronal process. So there is the temporal muscle. We're going to have also a medial pterygoid muscle, or musculus pterygoidus medialis. It starts from the pterygoid fossa and the middle plate of the pterygoid process of the sphenoid bone. It is attached to the pterygoid tubercle of the angle of the lower jaw. Lateral pterygoid muscle, musculus pterygoidus lateralis. The upper head starts from the subtemporal head and the subtemporal crest of the large vein of the pterygoid bone. The muscle bundles of both heads converge and are attached to the front surface of the neck of the lower jaw, the joint capsule and the joint disc of the temporomandibular joint. Maxillohyoid muscle, musculus mylohyoidus. Bundles start from the maxillohyoid line, go inward and backward, and form a seam along the medial line with the bundles of the opposite side. Bigastric muscle, or musculus digastricus. Muscle bundles of the anterior abdomen begin in the bigastric fossa. Here is the bigastric fossa. Go backwards and outwards to the hyoid bone. The posterior abdomen begins, here's the hyoid bone. The posterior abdomen begins from the masseter notch. Here's a masseter notch of the temporal bone, presses forward and downward, passing into a tendon. Here we could see this is a tendon with the gray color that connects it with the anterior abdomen. So here is the anterior abdomen of the musculus bigastricus, and this is the posterior abdomen. So it's very simple. The geniohyoid muscle, musculus geniohyoidus, it starts from the chin bone of the lower jaw. There's the chin bone. is located above the maxillohyoid. So here is the large, it is the maxillohyoid muscle, and the geniohyoid muscle, it lies above that muscle. So we said that it is located above the maxillohyoid muscle and is attached to the body of the hyoid bone. So here is the hyoid bone and here is the hyoid bone. So, but on this picture we don't see that geniohyoid muscle. We could see only on this picture. There are actions of masticatory muscles. Musculus masseter. It raises the lower jaw, moves it forward, and moves it to the side. Musculus temporalis raises the lower jaw, pulls it back, moves it to the opposite side. Musculus pterygoideus internus raises the lower jaw, moves it forward, and moves it to the opposite side. Musculus pterygoideus externus moves the lower jaw forward, takes it down in the opposite direction. Musculus digastricus lowers the jaw, pulls it back, and leads it to the opposite side. Musculus geniogrossus pulls the lower jaw back, lifts it up. And Musculus geniohyoidus lowers the lower jaw and moves it back. Here we can see the mimic muscles. There are laughing muscle, musculus risorius, muscle that leaves the upper lip, or musculus levator labii superiorus, muscle that lowers the lower lip, depressor labii inferioris, large zygomatic muscle, musculus zygomaticus major, muscle that raises the corner of the mouth, musculus levator anguli oris, muscle that lowers the corner of the mouth, musculus depressor anguli oris, and last it is the musculus orbicularis oris. The mimic muscles are involved in grasping, holding, eating, and making sounds. They play an important role in the acts of sucking and eating liquid food. There's the temporomandibular joint, or TMJ. It is a paired, combined joint which formed by the heads of the coronoid processes of the lower jaw, the mandibular fossa, and the articular tubercle of the temporal bones. So we could see also the articular disc between the mandibular fossa and the articular in the head of the processus coronoideus. Here is the articular disc. Most often, the head of the lower jaw is elliptical. So elliptical, if we call it elliptical, it is the picture B. We see that 60% of our patients may have this anatomy of the head of the lower jaw, 60%. And elongated in transverse direction. So if we could see in the last direction, it will be an elongated. However, there are other variations of morphological architecture. So the 25% is the type A, 12% type C, and type D only 3%. So this is these types of the head of the lower jaw, they are not pathological. These are anatomical varieties of the anatomical structure of the normal anatomical structure of the head of the lower jaw. Variations of the morphological architecture of the head of the lower jaw, but in the axial plane. Axial plane, we see it marked with a blue color. The most common anatomy in the axial plane of the head of the lower jaw, we could see on the picture A, which is marked with a blue color. We also see that 28% have the biconvex or convex on two sides. Number on the picture C, 22% have patients have the front surface which is concave and the back that is a convex. So the front is concave, back is convex, and this is flat, or we call it biconcave. Only 3% of patients would have this anatomy in normal. The articular surface of the mandibular fossa of the temporal bone is 2-3 times greater than the articular surface of the head. Fibrous cartilage covers only its frontal part, which is located in front of the petrous tympanic cleft of the temporal bone. Cartilage covers the articular tubercle as well. The front part of the mandibular fossa of the tubercle are surrounded by the articular capsule. Here we could see, not on this picture, but on this. Here all is the articular capsule. The articular capsule, which has the shape of a cone with the base at the top. The front edge of the base of the articular capsule is located in front of the articular tubercle. The back reaches the stony tympanic cleft. The capsule on the condylar process is attached in front along the edge of the head of the lower jaw, behind 1.5 centimeters below its rear edge. The joint cavity contains an articular disc or discus articularis made of fibrous cartilaginous tissue, similar to a biconcave lens. It divides the joint cavity into 2 floors, isolated from each other. So here is the lower floor and this is the upper floor. So there are 2 floors. The articular disc can move along the articular tubercle due to the fact that the articular capsule at the level of the lower floor of the joint cavity is stronger and better stretched, and the tendon fibers of the lateral pterygoid muscle are woven into the anterior medial edge of the articular disc. So they are the ligament apparatus of TMJ, temporomandibular joint, which mandibular ligament or ligamentum sphenomandibular, sphenomandibular ligament marked with a yellow color. The stellus mandibular ligament or ligamentum stylomandibular, it is marked with a red color. Lateral ligament or ligamentum laterale, ligamentum laterale, we couldn't see them. The sphenomandibular ligament, ligamentum sphenomandibular, stretched with the thin fibrous cord from the spine of the sphenoid bone to the tongue of the lower jaw. So here is the spine of the sphenoid bone, and here is located the tongue of the lower jaw. Delays its lateral and vertical movements. The stylomandibular ligament, red color, stretched between the styloid process, here is the styloid process of the temporal bone and the inner surface of the back edge of the branch of the lower jaw. It inhibits the forward, we move our lower jaw forward, so it extends or inhibits the forward extension of the lower jaw. Here we could see the transverse axis through head of the mandible. It is called axis of rotation. So here are the head of the mandible, and there are the axis of rotation. Here is the median plane, and the angle between these transverse axes must be 150. Here we could see on this right side here we can see the movement of the lower jaw. It is the protrusion. When we move our lower jaw forward, it's called protrusion. We saw that this corner, which is 150, it doesn't change, as also on all these surfaces, but we know. So the 150, it is the angle in normal, but all we are divided from each other. So in each patient, there could be different grades of this angle in normal. So here is the average of this angle. In the left corner, we see the movement of the lower jaw on one side. It could be left side or right. For example, this is the movement in the left side. And there we could see on the lower jaw two sides. The working side, which we use, for example, when we chewing, there is one side, it is a working side. And the other side, we call it a balance side. Here is the pennant angle. Angle between this medial plane in normal and this plane when we move our jaw, lower jaw, for right or left, for example. So here is the moving, but in the other direction. So we could see there is also the working side, the balance side, and the Bennett angle is also there and there. So when we talk about the pathology of TMG, we use the diagnostic of these Bennett angles in normal and in our patients. So the next slide is the sagittal movements of the lower jaw. Forward movements of the lower jaw are carried out by bilateral contraction of the lateral pterygoid muscles fixed on one side in the pits on the pterygoid process, on the other on the front surface of the head of the lower jaw by the articular disc. The forward movement of the lower jaw can be divided into two phases. In the first phase, the disc together with the head of the lower jaw slides along the surface. So you can make this. It is the first movement of the articular tabulum. And then there is a second phase. The sliding of the head is joined by its hinged movement around its own transverse axis. So we talk that there are two phases, second phase and first phase. The distance traveled by the head of the mandible during forward movement of the mandible is called the sagittal articular path. The sagittal joint path is characterized by the angle of the sagittal joint path. This angle is formed by crossing the line on the continuation of the sagittal joint path with the occlusal plane. We call this plane also the prosthetic plane. Transverse movement of the lower jaw. Lateral movements of the lower jaw occur as a result of contraction of the pterygoid muscle on one side during the movement of the jaw to the left. The right lateral pterygoid muscle contracts. In this case, the head on one side rotates around its axis, which goes almost vertically down through the branch of the lower jaw. At the same time, the head from the other side, together with the disc, slides along the surface of the articular tubercle. If the lower jaw moves, for example, to the right, then on the left side its head moves down and forward. And on the right side, it rotates around the vertical axis. So there are the different movements. The head of the lower jaw on the side where the muscle has shortened moves down, forward, and inward. At the same time, it crosses the path at an angle to the sagittal line of the articular path. This angle was first described by Bennett and is equal to 17 degrees. Chewing mechanism. Chewing mechanism you could see in these black and white color pictures. So there are 4 stages of chewing. Oh, sorry, there's. The position of the central occlusion. So here we can see it is the tongue and the relationship between tooth, the right left side. It is we called the position of the central occlusion. The lower jaw is lowered and moved to the side on the picture B. So we could see that the vector of these of the lower acids choose a change. Why? Because the lower jaw lowered and moved to the side. So there is a second phase of the chewing mechanism. The third phase is a lateral occlusion. Here is the lateral. So you could see that the angle on the right side, the long axis, are most common. On the left side, they are not in common. So here is the third phase. It is the lateral occlusion. And the fourth phase is the position of the central occlusion as it was before. So here is the mechanism there, and it begins from the central occlusion. So here is the simple mechanism of chewing. It's not hard to understand, so all this is very simple. The chewing mechanism is a set of mechanical processes that lead to grinding food in the oral cavity. The act of chewing consists of biting off, grinding, and crushing food. Mechanical processing of food in the oral cavity is carried out with the help of teeth, which together with the lower jaw perform a complex cycle of movements. Gizi presented the cyclical movements of the lower jaw in the form of this diagram. So it is called the diagram Gizi. The initial moment of the movement is the position of the central ratio jaw. Then 4 phases follow one after the other continues. We talked about it, and this is the text. So in the first phase, the jaw drops and moves forward. In the second phase, the jaw shifts to the side, to the working side. The teeth are closed on the working side with the same tubercles, and on the opposite side with different tubercles. So we could see here, these tubercles are simple, but these tubercles, they are different. In the fourth phase, the teeth return to the position of the central ratio of the jaws, and the chewing cycle is repeated again. After chewing, the jaw returns to its position, physiological rest. The act of swallowing. The oral cavity is closed by the sacral muscle of the mouth, and the jaws are compressed by the masticatory muscles, and the lower jaw becomes a fixed point in relation of the hyoid bone. The muscles of the floor of the mouth begin to work, including the muscles that lower the lower jaw, which tighten the hyoid bone, and thus the back of the tongue. The root of the tongue is a result of the contraction of the stylolingual palate, lingual, and to some extent, the stylohyoid muscles is also pressed against the hard palate, and the food lump enters the pharynx. The back movement of the lump is prevented by the palatal brackets, which are attracted to each other. Getting food into the nasal cavity is prevented by the fact that as a result of the lifting and tension of the soft palate, the connection with the nasal part of the pharynx is closed. At the same time, the upper one is shortened. The muscle is a constrictor of the pharynx. The passavan ridge formed in this case joins the raised soft palate and close to the nasopharyngeal space. So, periodontal disease. The periodontum, it is a ligament that holds the tooth root in the tooth cell. Its fibers in the form of thick collagen bundles are woven into the cement at one end and in the cellular process with the other, creating several grooves. Between the bundles of fibers there are spaces filled with the loose fibrous connective. They called interstitial tissue containing blood vessels and nerve fibers. Epithelial remnants or islets of Malasse are also located here. Functions of periodontium: supporting function, retention of the tooth in the dental cell, distribution of the chewing load on the fibers of the main substance and the fluid associated with them. Participation in teething is also the function of the periodontium. Proprioceptive. Due to the presence of numerous sensory nerve endings, mechanoreceptors that perceive the lead contribute to the regulation of chewing forces. Trophic function. Provides nutrition and vitality of the cement, especially the tooth pulp. Reparative takes part in restorative processes through the formation of cement bath in case of fracture of the tooth root and during resorption of its surface layers. Protective, provided by macrophages and leukocytes. Macroscopic structure of the tooth. The tooth consists of a crown and a root. The border between the crown and the root is the neck of the tooth. We call this the cervix of the tooth. So here with the red line. The lower part of the root, it is the apex dentis. Here is the crown. The main mass of the hard tissues of the tooth, it is a dentine. So the dentine, I don't know, is brown, is marked with this color. So here all is the dentine, which is covered with enamel. So here there's enamel in the crown. Within the hand with the root, cement in the area of the root. The hard tissues of the tooth limit the pulp chamber which contains the pulp. Crown and root pulp are distinguished. So here we could see, we could make it bigger. So here is the anatomic root. Here is the anatomic crown. There is the apical foramen. Due to the apical foramen, it is begin the root channel. Here is the cementodentinal junction between the cementum and dentine, and here is the pulp. Here is the dentino-enamel junction. So, if in the area of the anatomic crown, it is a dentin enamel junction, and in the area of the root, it is a cemento-dental junction. Here you could see the panoramic, orthopanoramic, the patient. There are incisors, we call them dentes incisive, canines, dentes canini, premolars or small angular teeth, dentes premolars, and molars or large regular or large angular teeth, dentes molars. Incisors and canines belong to the frontal teeth, premolars and molars to the lateral ones. So as we could see on this orthopantometric, here you could see there are incisors, there is the canine on the upper jaw and the canine on the lower jaw. Incisors and canines belong to the frontal teeth. So there is the group of the frontal teeth, the upper jaw, and the group of the frontal teeth on the lower jaw. Lateral groups, there is a first premolar, second premolar, first molar, second molar, and the third molar. So you can see the direction of this molar. This direction, this molar need to be extracted. Surfaces of teeth. Vestibularis, it is directed to the parietal lobe of the oral cavity. Labialis, directed to the lip. Buccalis, directed to the cheek. Facialis, directed towards the face. Oralis, directed to the oral cavity itself. Lingualis, directed to the tongue, only for the lower jaw. So if we see that there is a lingualis surface, so we talk about only the lower jaw. We couldn't say that there is a lingualis surface on the upper jaw. If the teeth have this surface on the upper jaw, we call them palatinalis. So palatinalis direct to the palate, but only for the upper jaw. Medialis, or also called mesialis, in the dental arch, directed to the midline. Distalis is in the dental arch, directed from the midline. Approximalis is a contact located between the crowns of adjacent teeth. Incisimalis, located on the cutting edge. Occlusalis, located on the chewing surface. Chewing surface, we talk about premolars and molars. We know that the frontal teeth have only the incisialis surface, but not the occlusalis. And the cervicalis is located in the area of the neck of the tooth. It's lying between the clinical crown and clinical root. So on this picture, we could see labial, mesial, lingual, and distal. Here is the lower central incisor, for example, or second incisor. So this surface is labial, lingual as it is located on the lower jaw, mesial, and distal. So here is the mesiolabial line angle, the distal labial angle, the distal lingual line angle, and the incisor cervical dimension. And here is the incisalis, these teeth. Signs of group membership of the tooth. There are two signs. First of them, it is the crown angle sign. The second is a sign of crown curvature. And the third is a sign of the position of the root. The first, crown angle sign. The angle between the incisal edge or chewing surface and the medial surface is sharper compared to the angle between the incisal edge and the distal surface of the crown. It was the first sign. The second sign is a sign of crown curvature, which is characterized by a steep curvature of the vestibular surface near the medial edge and a gentle slope of this surface to the distal edge. A sign of the position of the root is characterized by a deviation of the root distally relative to the longitudinal axis of the crown. So, here we could see the picture. On this, we could see a sign of the position of the root. So we understand that the deviation of the root must be distally. If it is a midline, so this root must curve distally. So we can say that this root is from the right side and this is from the left side. So we couldn't change them because they have a sign of the position of the root. And we understand this. A sign of crown curvature. We could see here. And crown angle side. It is very important to know that crown angle side, when you make the composite restoration, for example, the central tooth, you know that if there is a midline, you must make your crown that the angle to the midline must be sharper than the distal. So if we make the opposite tooth, for example, it is the crown, there we could see a root. So here is the crown angle side. This is very important to know. Central upper incisor, the largest of the entire group, has a shovel-shaped crown. The uninhibited cutting edge has three tubercles that continue along the vestibular surface in the form of barely noticeable ridges. The lingual surface of the crown is concave in the longitudinal direction. Along its edges, there are two longitudinal ridges that gradually thicken to the neck and merge into a tubercle. On the contact surface, the crown has the shape of a wedge, narrowing to the cutting edge. A well-defined sign of curvature of the crown, a noticeable sign of the position of the root. The cavity of the tooth corresponds to its external contours. Its longitudinal axis is located closer to the vestibular surface of the crown. The lumen of the root canal is relatively wide and straight. Lateral upper incisor, smaller than the central one. The shape varies. The ridges on the vestibular surface are weakly expressed, but on the palatal surface they are clearly defined as the dental tubercle. In front of the tubercle, a blind pit is visible. The concavity of the palatal surface is more pronounced than that of the central incisor. The distal surface of the crown often has the appearance of a rounding that passes into the cutting edge. The lateral incisor has well-defined signs on the angle and curvature of the crown. The cavity of the tooth is small. Its configuration resembles its crown. The root channel is wide enough. Central lower incisor, the smallest of the whole group. It has a chisel-like shape. The usual signs of belonging to the tooth are absent. The tooth tubercle is weakly expressed. The lingual surface has a slightly concave relief. The cavity of the tooth in the frontal plane has the form of the triangular gap. Lateral lower incisor. It differs little from the central one, but it's larger. The distal edge is longer. Signs of the teeth are better traced than in the central incisor. The cavity is the same, and the channel sometimes bifurcates in its midline part. At the same time, one part of it's located closer to the vestibular surface of the root and the other to the lingual surface. Apicanine. It has a spear-shaped crown. There is a thickening in the form of one well-defined ridge on the vestibular surface. Both contact surfaces gradually converge to the cutting edge. The cutting edge consists of two slopes that converge at an angle and form a gaping tubercle, located closer to the mesial surface. The mesial surface is higher than the distal one, and the mesial slope of the rupture tubercle is shorter than the distal slope. On the lingual surface, there are two recesses between three ridges branching from the dental tubercle. The cavity of the tooth begins with a cone-shaped protrusion that expands from the center of the crown to the neck, and then gradually passes in the root canal, which narrows. Canines have the longest root. Lower canine is smaller than the upper. It resembles the upper lateral incisors in shape, although its cutting edge and vestibular surface are similar to those of the upper canine. The cavity of the tooth corresponds to the cavity of the upper canine, but the root cavity is more compressed in the mesial distal direction. Sometimes it is bifurcated. First, upper premolar. Its vestibular surface resembles the canine of the opposite tooth row. It has the opposite sign of crown curvature. The slope of the vestibular surface in the mesial direction is more gentle than in the distal direction. The lingual surface is more convex and has a smaller size. The chewing surface is oval, divided by a transverse furrow or fissure into buccal and palatal tubercles. The palatine tubercle is smaller than the buccal tubercle. The root is more often bifurcated. The sign of the angle of the crown is pronounced. The second upper premolar. It has a smaller crown, oval in diameter. The root is usually single and is cone-shaped. Signs of the surface of the tooth are well expressed. The cavity of the tooth is funnel-shaped, compressed in the mesial distal direction. The first lower premolar, it has a rounded crown. The buccal tubercle is larger than the lingual tubercle. The vestibular surface is convex, inclined orally. The transverse interdental groove is divided by the interdental ridge into two pits. The roller forms two areas of the chewing surface. Pronounced signs of the curvature and angle of the crown. The cavity of the tooth is slightly compressed in the mesial distal direction. The root canal is one, it can be bifurcated. So here we could see, here is the lingual cusp, here is the buccal ridge. There are mesial developmental groove and the distal developmental groove. So there are two grooves on both sides. Yeah? The mesial fossa and the distal fossa. There is a transverse ridge, triangular ridge, distal developmental groove, distal marginal ridge, distal fossa, and triangular ridge. Second lower premolar. It has a spherical crown. The predominance of the buccal tubercle is less pronounced than that of the first premolar. Pits on the chewing surface can merge into a horseshoe-shaped groove. Signs of the surface of the tooth are clearly expressed. The root is longer and larger than that of the first premolar. The cavity of the tooth has two protrusions corresponding to the cusps. First upper molar. It has a massive diamond-shaped crown with the largest diagonal from the buccal mesial to the palatal distal tubercle. Three furrows are shaped. The chewing surface is divided into four tubercles. Sometimes another abnormal tubercle of Carabelli, it is also called an enamel drop, is formed on the palatal surface of the crown in the area of the palatal medial tubercle. The second upper molar. It resembles the Carabelli tubercle in shape and presence of the first molar, which is slightly smaller in size. Options with three chewing tubercles are possible. The first upper molar is marked on the left side and the second upper molar on the right side. The first lower molar, it has a cubic shape with 5 masticatory tubercles. 2 of them are vestibular, 2 are lingual, and 1 is distal. The medial tubercles are larger than the others, and the distal tubercle is the smallest. The middle root is longer than the distal one. The cavity of the tooth is wide. Its bottom passes into 3 root canals, 2 of which are located in the nasal root and 1 in the distal one. The second lower molar, it has a cubic shape smaller than the first. The chewing surface is cross-shaped with grooves that demarcate 4 chewing tubercles, clearly expressed signs of the surface of the tooth. Conventional designations are accepted in dentistry for each tooth, and the main conditions of the teeth, which greatly facilitates record keeping. The dental rows are divided into 4 quadrants, each of which is assigned a serial number that corresponds to the sequence of the examination from 1 to 4. And if we talk about permanent dentition and we have a patient as a child, then we will say that it has from 5 to 8. So for example, it is the upper jaw right side. So this make a little bit closer. Oh, here is the central incisor on the upper jaw. And we say that it is the tooth number 11, number 12, the canine is number 13, and the last molar will be number 18. So here is the upper jaw from the right side. So it has number 1. Left side has number 2, so it will be the teeth number 21, 22, 23, 28. So it is number 2. As a clock, so we could say that there is a clock. So 1 is a 2 quadrant, is a number 3 segment, and number 4 segment. So if we talk about the lower jaw, for example, the first inside of the lower jaw from the right side will be number 41. So it's a 4th segment and teeth number 1. So we talk that it is number 41. If it is the last 3rd molar, it will be number 48. And if we have a child, for example, we know that child don't have 36, 28 teeth. It has only 20 teeth in primary dentition, not in the mixed dentition and not in the adult. It is a primary dentition. Only 20 teeth, 5 on each segment. So here we could, here we could see. Here we could see child. So only 5 teeth in each segment. So upper jaw maxillary, right side. The first central incisor on the maxillary jaw from the right side will be number 41. Not 11, 41, because we talk about child is the primary dentition. If there would be, for example, a mixed dentition, there would be a first permanent molar. It is number 6. It would be number 16, but the child will have teeth number 41, 42, 43, 44, 45, and 16, because it is a permanent teeth. So the designation of each tooth consists of 2 numbers. The first number means the quadrant in which the tooth is located, and the second, the conventional number of the tooth. Thus, the upper right central permanent incisor is designated as a tooth number 11, read II.1 or 11. The lower first second prominent molar is designated as tooth 37 or tooth 37, and the lower left second temporal molar is designated as tooth 75 or 72775. American tool designation system, or is also called the universal number system. In our country, in Ukraine, we don't use the American. We use this, which we'll talk about before. But here you could see the American tool designation system. Maybe it is important to know this system. So here there are 32 tooth. For example, tooth number 1 is the third molar, the upper jaw from the right side. From the left side, the third molar will be number 16. So also the logic and as the clock 1, 2, 3, 3, 4, 5, 6, and to 32. So as a clock. Here is the American system or universal number system. Now a few words about dental arch. Dental arch is a line drawn through the vestibular edges of the occlusal surfaces and the incisal edge of the crown. So there are, in dentistry, we use 3 arches: dental arch, alveolar arch, and basal arch. And we need to know that the basal arch, it is, if the lower jaw, it is shorter than the dental arch. The alveolar arch between them. For example, okay. The dental arch is a line drawn through the vestibular edge of the occlusal surface. So dental arch, yes. Number 1 is a dental arch. What? Drawn through the vestibular edge of the occlusal surface in the incisal edge of the crowns. Alveolar arch is a line drawn along the ridge of the alveolar process. Basal arch, number 3, is a line drawn through the tops of the roots. Here is the basal arch of the maxillary. Here's the basal arch of the mandible. Here is the alveolar arch of the maxilla and alveolar arch of the mandible, and only one dental arch. It is important to know. The sagittal occlusal curve. Sagittal occlusal curve, we called it also the Spear's curve, passes through the tops of the cusps of the teeth of the lower jaw. The deepest point is on the first molar in normal, but if you will study the orthodontic, you will understand that the curve of Spear could have different variations, not only as shown as there on this picture. So this is the curve of Spear. If we talk about the pathology, for example, the class 2 patients, class 2 division 1, they have a stepped curve of Spear. It will have this like a step. It is also called a curve of Spear. If you would study the Tweed's orthodontic courses from Tweed Foundation, after orthodontic treatment, they make a disocclusion in distal areas, and they at the end of the treatment they have, here is the lower jaw, upper jaw, and the lower jaw. And here is the disocclusion, and it is also called the curve of Spear. So you need to understand that the curve of Spear, here is this curve of Spear, but it could have different variations due to the pathology of the patient's dentition. Here is the curve of Spear. We have also the curve of Wilson. It is indifferent in another direction. It is a transverse occlusal curve. Transverse occlusal curve or Wilson's curve passes through the tops of the tubercles of the lower jaw in the transverse direction. So if we talk about orthodontic treatment, we use, for example, if it is not removable appliances, for example, we talk brackets. We call them brackets, not removable. We can make a different chalk. For example, some edgewise, some MBT or Roth, different descriptions. They have different torque of these teeth. So this curve of Wilson could be also different. So for example, we have this torque and this torque. Here is the curve of Wilson. For example, if we have a cross bind, we change this torque. So it could be a plus torque. So the curve of Speer could be deeper, or the minus torque, it would be not so deep, it would be also flat. So it is all called the curve of Speer, but it has different variations. So we remember that this is the curve of Speer and this is the curve of Wilson. But it is the relationship between the rows of the teeth in the central state occlusion. Central occlusion is the closure of the dental rows, in which case the teeth have the maximum number of contact points and the articular heads of the lower jaw, which are located with the help of a disc at the base of the slope of the articular tubercles. Physiological bites. Physiological bites include orthognathia, direct bite, physiological prognathia, and physiological opistognathia. And there are pathological bites. Pathological upper prognathia, distal bite, lower prognathia, prognathia, medial bite, deep bite, open bite, and cross bite. So all these are pathological bites. Orthognatic bites. The upper dental arch has an elliptical shape. The lower one has a parabola shape. On the upper jaw, the dental arch is larger than the cellular one, and the cellular one is larger than the basal one. So as you remember, we talked about these arches here. Cellular one, basal one, cellular one, cellular arch, basal arch, dental arch. So as you could see there, that the upper dental arch has elliptical shape. The dental arch is larger than the cellular one, and the cellular one is larger than the basal one on the arch, upper arch, maxilla. Each of the teeth usually close with the two antagonists, but one of which is called the main one, and the second one is called the additional one. But there is the exception. The upper wisdom teeth, it is the third molar, and the lower central incisors, as you can see in the mirror, the lower central incisors contest only with one tooth on the another jaw. So they have only one antagonist. The teeth of each tooth row adjacent to each other touch each other with contact points located on the proximal surfaces. The height of the dental crowns gradually decreases from the central incisors to the molars. Canines are in section because they have a very long crown. The upper front teeth overlap like scissors, as you can see in the mirror. The upper teeth are overlap the lower teeth by about 1/3 of the crown. It could be from 1.5 millimeters to 3 millimeters. This we talk if you would read the literature in English. There it is called an overbite and overjet. It is the distance between the upper and lower jaw in sagittal. So the upper front teeth overlap like incisors, lower teeth. We call this an overbite, and it in normal must be 1.5 to 3 millimeters, but it is only in the adult patients. In child, another. The median lines between the upper and lower central incisors are on the same sagittal plane. The buccal cusps of the upper teeth are located outwards from the cusps of the lower teeth, and the buccal cusps of the lower teeth are inward from the cusps of the upper teeth. So the upper palatal cusps fall into the occlusal fissures of the lower teeth, and the lower buccal cusps fall into the cusps of the upper teeth. The external or buccal and internal tubercles of both the upper and lower chewing teeth are located at different levels on both sides of the jaws. The front section of the jaws through the chewing teeth, which goes from right to left or in the opposite direction with a transverse curve, convex on the upper teeth and concave on the lower ones. The anterior buccal tubercle on the upper first molar is located on the buccal side of the first lower molar in the transverse groove between the buccal tubercles and the posterior buccal tubercle of the upper first molar, which is located between the distal buccal tubercle of the first lower molar and the medial buccal tubercle of the second lower molar. Here you can see the direct bite. Direct bite differs from orthodontic in that the cutting edge of the upper teeth do not overlap. It is the overbite. They do not overlap but fall directly like forceps on the cutting edge of the lower teeth. In the area of the lateral teeth, the relationship between the teeth is the same as in the orthodontic bite. As a result, in the presence of a direct bite, sometimes faster wear of teeth occurs than in the case of an orthodontic one. Under such conditions, the surfaces of the teeth are polished, the latter the resistance to caries are further held in the cells and are affected by periodontitis or periodontitis less often than in other forms of physiological bite. Prognathia. Prognathia is characterized by a protruding position of the upper jaw as a result of the distal shift of the lower jaw or the forward movement of the upper jaw. There is a violation of the closure of both the front and lateral teeth. In the case of prognathism, the teeth of the upper jaw are pushed forward and there is a gap between them and the lower teeth. Often, the lower teeth touch the mucous membrane, damaging it during closing the jaws. In the presence of prognathism, a violation of the proportions in the area of the molar teeth leads to the fact that the anterobuccal tubercle of the first upper of the first molar first pupils of the same name of the lower molar, and sometimes in the closing gap between the premolar and the buccal tubercle of the first lower molar. In case of pronounced prognathia, the teeth of the upper jaw very much protrude forward, pushing out of the upper lip, from under which the cutting edge of the teeth are visible. We call this especially the bird beak. Their face is like a bird beak. Progeny. In the case of progenic ratio of the dentition, the lower jaw is pushed forward, as a result of which the lower front teeth overlap the upper ones at the same time. If the lower jaw protrudes slightly, contact is maintained between the front teeth. Foot is bitten off with the front teeth in the case of similar jaw relationships. In the presence of a significant displacement of the lower jaws forward, a gap is formed between the teeth. Biting food with the incisors becomes possible and is transferred to the side teeth. Since there is a medial shift of the lower jaw, the anterior buccal tubercle of the upper first molar comes into contact with the posterior buccal tubercle of the lower molar of the same name, or enters the closing gap between the first and second molars. Deep bite. Deep bite. Deep bite is characterized by a significant overlapping of the frontal teeth of the upper jaw with the frontal teeth of the lower jaw, in the absence of incisor-cuspid contact. The cutting edges of the lower teeth can touch the neck of the upper teeth. Sometimes there is no contact in the teeth, and the teeth touch the gums and damage them. Lateral incisors are closed as conditions of orthodontic bites. In the presence of a deep overlap anatomic variant of orthognathed by the upper front teeth overlap the lower ones by more than 1/3 the height of their crowns, but the incisal bump contact is preserved. In the case of a deep bite, it is absent. So if the patient have a deep bite, you can see that we don't see the lower incisors. The patient with these deep bite often have problem with TMJ, temporomandibular joint. So here is the deep bite. Open bite. There is no closing of the front teeth, and sometimes the premolars, only the molars come into contact. If we talk about orthodontic classification of the open bite, there are two types, type 1 open bite and type 2 open bite. We know that the latest teeth which is in contact, it could be a second molar. So here is the type number 1. Here is the type number 2. And this is from the left and from the other side, there are the open bites. It is the first type. We see that the disocclusion begins on the second molars. So here is the second, there are the second molars, and there are the incisors. So we call this is the first type open bite. And there is the third type of the open bite, when the disocclusion begins only in the area of the premolars. So here, molars, second molar, first molar, second premolar, first premolar, and the upper lower jaw, they are in contact. But the disocclusion begins in the area of the first premolar. We call that this is the second type of the open bite. What can cause the open bite? It can be a pathology of breathing. If the patient have a mouth breathing, they do not breathe with their nose, they breathe only with their mouth. The masticatory muscles, they push on the upper and the lower jaw from both sides, and the patient have an overbite. It could be also an macroglossia if the lingual have big shape. There could be a macroglossia, and there are also, if we talk about macroglossia, there also must be spaces between these teeth. So the spaces, and when you said the patient, open your mouth and show me your tongue, you can see that it is a macroglossia. So the tongue is very big for this mouth and for this dentition. And then we make a specific surgical operation to make the shape of the tongue less. And then we make an orthodontic treatment. If we will make an orthodontic treatment without changing the size of the lingual, if the patient has a macroglossia, we will have a relapse after we, in the retention period, we will have a relapse because the force of the tongue is very big, and the patient will have a relapse. And we could not take, and we could not say that this orthodontic treatment was great. So today, the time of our lecture is ended. If we talk about this lecture, there are 50 or 40 slides. We could continue from this slide on our second lecture. Or if you want, if you don't want, we could begin from the second lecture. So thank you and goodbye.